टेंडो एकिल रप्चर। हम लोग बात कर रहे हैं टेंडो एकिल रप्चर। दिस इज अ एंकल फुट केस और वाइवा बुक से है। सो व्हाट इज टेंडो एकिल रप्चर? Getting a case with acute rupture is quite unlikely. Getting a case with acute rupture is quite unlikely, and one must prepare for neglected injury. A theoretical knowledge of various cause and diagnosis will be legible to pass. One should have a clear idea of management. Read 2 to 3 times DNB candidate, MS DNB candidate, MS candidate are very unlikely to get this case in preference for other examination cases. A diagnosis: a patient is a 47-year-old male with 3-month-old neglected rupture of tendo-Achilles of left side, ruptured Achilles tendon, tendo-Achilles rupture. So finding history means sudden onset pain over back of ankle associated with snap and inability to walk, acute onset swelling, previous history of minor trauma, no treatment taken, laboral examination, scar mark, tenderness and bruise, acute case, palpable gap, irregularity, old cases on posterior aspect of lower leg in the region of tendo-Achilles, inability to toe walk, positive Thompson, Simmons calf squeeze test, O'Brien's needle test, Copeland sphygmomanometer test, Mattel's knee flexion test, weakness of gastrocnemius soleus and painful plantar flexion, especially when resisted. Thompson test on left side is normal. Patient squeeze, where a squeezing of calf produces plantar flexion at ankle, while on the right side is a patient with torn Achilles tendon where there is absence of plantar flexion with a squeezing of calf. So Mattel's knee flexion test in resting position with patients prone and knee bent to 90 degree. The foot with torn Achilles tendon so increased dorsiflexion. How do you test for tendo-Achilles discontinuity? Apart from history and local palpable gap and plantar flexion weakness, the special tests that help diagnose the discontinuity of tendo-Achilles are Thompson-Simond Doherty test. Patient prone, squeeze the calf muscles of the patient's passive plantar flexion of foot, demonstrate continuous tendon. After 7 days, neglected case due to intervening scar formation. The test may be falsely negative. Needle test of O'Brien. Insert a hypodermic needle 10 cm above insertion of tendo-Achilles so that its tips is just inside the tendon. Alternatively, plantar and dorsiflexion foot if the outer portion of needle point cranially on the dorsiflexion, the tendon is supposed to be intact. Sphygmomanometer test. Wrap the cuff around calf region and inflate it to 100 mmHg. If then on dorsiflexion of foot pressure rises to 140 mmHg, then it indicates intact tendon. Knee flexion test. With patient prone, ask the patient to flex knee to 90 degree neutral position. Dorsiflexion of ankle suggests torn tendon. Reverse Silfer Skiold test, not very popular. With knee in full extension, ankle dorsiflexion here is solely restricted by tendo-Achilles. Measure the range of dorsiflexion at angle, more on injured side compared to normal side. Single leg heel raised test. Ask the patient to stand on injured leg with heel raised. Not possible with torn Achilles tendon. What are the fallacies of Thompson test? A positive Thompson Simon test is supposed to clinically demonstrate complete rupture, in particular dependent on integrity of soleal part of the tendon. O'Brien, however, demonstrated that rupture of gastrocnemius part also produce a positive test, and hence describe the needle test. Conversely, also in cases where gastrocnemius aponeurosis is separate from soleus, the Thomson test may be falsely positive, as the squeeze has predominant effect on gastrocnemius muscle belly rather than soleus. The treatment decisions are often based on whether tear is complete or partial, whether soleus is involved, rendering Thomson test insufficient. Why is 10 cm chosen as a point for O'Brien test? The following reason explain the rationale. In type 1 junction, gastrocnemius aponeurosis separate from soleus, the gastrocnemius tendon joins the soleal tendon 12 cm proximal to insertion. In type 2 junction, gastrocnemius inserting into soleus itself, the tendon is composite from beginning. In any case, the tendon is single unit, some 10 cm proximal to insertion. At the same level, the plantaris tendon is comfortably medial to Achilles tendon, while the sural nerve migrates laterally, preventing false negative test of nerve injury respectively. What is tennis leg? Rupture of gastrocnemius musculotendinous junction is called tennis leg. Other types of rupture are complete Achilles tendon rupture and partial tear. Why is the tendo-Achilles called so? According to famous legend, Achilles was the warrior of Homer-led Iliad, who was made invincible by his mother by immersing him in the river Styx, holding his heel, which remained untouched by water and hence vulnerable. This tendon, being the strongest tendon and location resemblance in paradox, has been so labeled. What is the blood supply of this tendon? Three sources deriving vascularity from both posterior tibial and lateral peroneal artery. Number 1. Musculotendinous junction surrounding connective tissue, bone tendon junction. The vascular supply is disputedly precarious in middle portion or 2 to 6 cm from insertion of tendon, and skin directly posterior to the tendon is relatively sparsely supplied. Where does the rupture commonly occur and what are the causes of rupture? The weak area of tendon is supposed to be 2 to 6 cm above insertion, where the vascularity is supposed to be precarious. However, there is no site preference with trauma. Various causes listed are as follows: collagen disorder, genetic, inflammatory and autoimmune mechanism, degenerative and repetitive trauma, drugs, corticosteroid and fluoroquinolones, exercise-induced hyperthermia within tendon, mechanical theory, eccentric loading, sudden loading with incomplete synergism of agonist muscles, insufficient plantaris, which is not able to maintain tension in tendo-Achilles, ischemic injury to tendon, age-related vasculitis and collagen disorder, torsional ischemia due to vasoconstriction of intratendinous vessel. What are the various pathognomic mechanisms? Various factors lead to development of weakness of this tendon that ultimately fails under load. The various pathologic changes that have been proposed, finally leading to weakness and hence rupture of tendon, are tendinosis, paratendinitis, paratendinitis with tendinosis. The term tendinosis describes various degenerative changes within tendon, hyaline, mucoid, myxoid, fatty, fibrofatty, etc., that may arise out of various above listed causes. Often tendinosis is not symptomatic and is realized only on rupture of tendon. Repetitive trauma or inflammatory condition produces paratendinitis, which may be later accompanied with tendinosis and is often painful before rupture. What will you do next for this patient? I will confirm the diagnosis only if there are atypical findings on clinical examination by radiological investigation. What are the findings on plain X-ray? Lateral projections, loss of posterior border of Kager triangle or complete disappearance. Fat-filled triangular space in front of tendo-Achilles is suggestive of torn tendon. Twagger sign involves measurement of angle of posterior skin surface seen on lateral projection with disappearance of triangle. The angle increases to 130 to 150 degree. Exostosis showing into the tendo-Achilles is identified on radiograph that may be the site of injury. Fracture, osteoporotic bone are weaker than the bone tendon junction. Same is the case with Haglund deformity. What is the most specific and sensitive investigation to diagnose a tendon rupture? MRI. Contrast enhanced is better if infection is suspected. How will you manage this patient? After confirming complete rupture of tendon, Achilles tendon, a symptomatic patient with disability needs surgical reconstruction. I will mobilize the gastrocnemius and soleus component of the complex, and after flexion of knee and plantar flexing the ankle, try to approximate the end without tension and do an augmentation with plantaris tendon or turn down of two flap of gastrocnemius aponeurosis. Nowadays, I have instead switched to augmentation with FHL tendon regularly to improve the outcome, especially delayed outcome, because late failure and recurrent tears are common. If the ends cannot be approximated, then I will use the peroneus brevis dynamic tendon transfer, rather a splint of white and cranic for reconstruction of tendon. Are there any guidelines for the treatment of chronic Achilles tendon rupture? Classification exists but are not popular, and couture treatment is often practiced. Mersenne classification: type 1 defect 1 to 2 cm long, end-to-end repair and posterior compartment fasciotomy. Type 2 defect 2 to 5 cm VY lengthening with or without tendon transfer. Type 3 defect more than 5 cm tendon transfer alone or combined with VY advancement and augmentation. Kawada classification: type 1 partial tear, conservative management. Type 2 complete tear 3 cm defect, end-to-end repair. Type 3 3 to 6 cm defect, debride plus tendon transfer with or without augmentation. Type 4 more than 6 cm defect, debride plus tendon graft plus minus augmentation. Confused? Better not to be. Leave apart the author themselves didn't evaluate utility of the classification. Be assured you will not be asked these unless you are getting gold medal. How do you manage acute tear? Simply, if the tendon ends can be approximated, then I will use an end-to-end suturing with modified Kessler method and plantaris augmentation. If the end cannot be approximated, then I will use complex reinforcement methods such as Lindholm technique with turn down gastrocnemius aponeurotic flap with plantaris augmentation. Postoperatively, I will immobilize the repair in above knee cast, in flexion at knee and plantar flexion at ankle. After 2 weeks, suture are removed and further immobilization in below knee cast is done, which is followed by gradual dorsiflexion of ankle over further 2 weeks and protected mobilization. What other methods are available for repair of tendon? Fascial reinforcement, artificial tendon implant, Marlax and collagen prosthesis. Do you know of any other method of repair? Percutaneous method of Ma and Griffith. What is the role of non-operative treatment? Constant fight between supporter of non-operative versus operative treatment remains unabated. With more recent publications, the disparity has more clouded. It is for a surgeon preference and to his experience to decide between the two. A combined conservative orthotic regime has recently been reported with excellent result. These methods are based on the premises of not injuring the already precarious blood supply to tendon through anterior mesentery and paratendon, and definitely and should be used for partial tear. Do you know any popular surgeon who suffered from Achilles tendon rupture? John Hunter in 1767 suffered complete tear while dancing. He treated himself with calf bandage and raising shoe heel with excellent result. Why is re-rupture common after repair or reconstruction? Native Achilles tendon is rich in type 1 collagen, while the healing tendon has high percentage of weaker and poorly organized type 3 collagen has resistant to stretch. What factor determine good healing of tendon? Preservation of paratendon, good approximation, and prolonged immobilization in equinus position are important for good healing of tendon.